Hi everyone, my name is Kushal Gadhia. I'm representing ACE together with my colleagues Victor and Rahul, and we will be discussing management of the worn dentition. I will not insult your intelligence, but for purposes of completion, tooth wear is a general term which describes the surface loss of dental hard tissues from causes other than caries, trauma, or as a result of developmental disorders. And as we all know, the etiology is linked to either attrition, abrasion, erosion, or abfraction. And usually it's multifactorial in a number of patients. Here are some examples where we see either erosive cases or attritional cases, and the characteristics are usually described, for example, in erosive cases by the cupping defects and the where facets don't match against the opposing teeth, but they do in cases of attrition. Likewise, we have lesions that occur in the cervical areas of the teeth, which are usually V-shaped or what we classify as abfraction. Whilst I don't want to go into the details of the etiology, usually patients present quite late with tooth surface loss with concerns. It is extremely important that we diagnose and manage tooth wear at a very early stage, particularly when you see tooth wear in patients that you wouldn't normally expect to see in patients of their age range. And it is sadly sometimes patients don't understand what consequences they could face in the future if they leave it unmanaged, or the costs involved in managing it, or the systems we work under which don't allow us to manage this as well as we want to manage where possible. But we need to do the usual, take good details, what their main concerns are, medical and dental history. But very importantly, you need to understand patients' current as well as previous dietary habits. I'm not usually a big fan of taking 3-day diet histories because I found that they usually are biased, but one done within the last 24 hours, face to face with the patient, what you had for breakfast, what did you drink when you were thirsty, what do you normally have for lunch, do you enjoy particular foodstuffs more than what other family members do. Classic examples will be ketchups. I drink a lot more Diet Coke. I go to bed with a bottle of soda next to me. I drink a bottle of whiskey every night. There are little things that we can pick up from patients interrogating them, but very subtly, and making them realize that some of their habits are perhaps not favorable to their outcomes. Usually these patients don't present to us in pain unless it's in very late stages. The usual concerns are, I feel my teeth have become smaller, or they're chipping and breaking. Pain is usually a very late feature and sometimes rarely present because of deposition of tertiary dentin. Aesthetics is also a big concern in some of these patients, particularly when it gets to the severe stages. From the medical and dental point, we need to ascertain some key points, but I find that there are a large number of patients that I see whereby I notice palatal wear involving the maxillary anterior teeth, and it usually reflects some sort of intrinsic wear. With this sort of intrinsic wear, some of these patients are not aware that they have this wear or any other medical conditions that could be linked with it. It's usually either caused by eating disorders, bulimia for example, or it could be caused by salient gastric reflux. And after ensuring that we've covered as many bases as possible, if we still can't get to the etiology, I will refer the patients to their general medical practitioners to investigate whether there is any silent, any quiet, i.e. patients are not aware of it, type reflux. And I've had one case where the patient has had to undergo gastric procedures and I was the first person to pick up and diagnose and manage her from a dental point. When it comes to managing tooth surface loss, tackling the etiology, as we've discussed in the previous few slides, albeit briefly, is extremely important, because if we don't, any treatment we do will, as a consequence, fail. The etiology will result into failure of any restorative work we do. I find managing tooth wear cases relatively straightforward if, after handling the etiology, we instate some of the preventative measures. We then understand how to control patient's occlusion, and then managing the sequence of treatments. And this is what I want to try and show you. From a preventative point, I engage with my hygienists and therapists and nurses and have a very strict protocol for patients to follow. They undergo 3 monthly gum maintenance appointments with my hygienists and therapists. They undergo good oral hygiene instructions, and these are regularly monitored to the highest level of standard. Because if they're going to have direct or indirect restorations put in their mouths, I want these restorations to last. I don't want their oral hygiene to lapse. We should make it clear the difference between physiological and pathological tooth surface loss is whereby you do not see that level of tooth wear in a patient of a similar age group. So if you have an 80-year-old patient who's had teeth in service for between 60 and 70 years in function, you will anticipate some wear and tear. But that level of tooth wear in somebody who is 20s or 30s or 40s is perhaps not what we would see in other patients of a similar age range. So taking that into consideration, that's how I will differentiate between what I need to manage and what I don't need to manage. Patients who then decline treatment, Adam in this case, he was 18 years of age, drinking lots of dietary erosive products, and as you can see, you wouldn't expect that in someone of his age. His teeth had become very thin. You can see the enamel, which is unsupported and shining through around his maxillary incisors and beginning to chip, as well as all the lesions that you see in the cervical margins of the teeth. After smoothing these surfaces, you can protect them with a little bit of composite so that they have some bulk to and the volume to the tooth, and then subsequently construct them with a protective splint until they are in a position to initiate and fund their treatment, leaving Adam in the state he presented with, even though he is unable to afford comprehensive treatment, is, in my opinion, sometimes negligent unless they decide, after having all the information we've provided, including let me smooth and round off your teeth, or let me protect them with a little bit of composite to make them thicker and make you a splint, a treatment that doesn't take much time or costs, then I think if we don't do that as a minimum for tooth wear our patients, then we are being negligent in what we do. If the patient declines to have any of this and understands the risks of further chipping, wear, endodontic problems, teeth becoming smaller, harder to manage, costs increasing, etc., and refuse to have a splint to protect the teeth until such time that they're able to start treatment, then it is very important for us to be able to document that, as well as write a follow-up letter to our patients explaining we've had this discussion, you've declined to undergo very simple procedures to control or to protect your teeth, but we'll be more than happy to see you when you're ready to start your treatment. This little letter usually means patients will reflect upon it and may perhaps come back in 3 or 6 months' time, when even more often than not you find another tooth or couple of teeth have chipped, and it's easy to say to them, hey buddy, I did tell you this last time, but if you're still considering it, I'll be happy to manage it for you. I'm a very big fan of ensuring that a lot of tooth wear cases undergo through the ABC or ABB protocol, which is where necessary, please consider orthodontic treatment first, because otherwise whatever you do from a restorative point, if the teeth are not in the correct relationship, your restorative treatment could be compromised as a consequence. A classic example is where someone doesn't have perfect canine relationships or have got very large oviducts. Then ensuring you get good anterior guidances or canine excursive movements can be very tricky. In addition to exactly what I said in the previous slides, informing and making sure patients understand that orthodontics, whilst may take a few months to a couple of years depending on the complexity, is an essential part in their treatment program to ensure what we do from a restorative point will also remain protected. And if they then decide not to have that done, the same protocols apply. Record and subsequently write a letter to explain this to them. On completion of the aligning or the orthodontic treatment, I would always offer patients the option of bleaching their teeth. Now, I found that where I have given patients this option but they have failed to do so, when I come to doing some of the composite work, some of their very dark teeth do not blend as well with the composites we have. So I will perhaps include the whitening part in my restorative program with the patients, discuss that that's what I'm doing, but I'm offering this as a free treatment for you, just to improve the base color of the teeth. And that doesn't necessarily mean taking anyone from an A3, A4 shade to a B1 shade, but you can stop somewhere between A1, A2 relative to their age. And a good way of assessing this is matching the white of the eye to the white of the teeth. And I've had numerous cases whereby taking someone from a darker white eye shade to a very white teeth shade just doesn't fit well with their face. If that's what they prefer to choose, then the beauty lies in the eyes of the beholder, and let them make that choice. They will stop the whitening when they're ready before we start restorative phase. And then coming to the restorative phase, there are various ways of managing this, and we will discuss some of these today. Most, if not all, restorative management of tooth wear happens in the reorganized state. By that, the minute we open patient's intercuspal position, their current intercuspal position, and that could be as little as adding a bit of edge bonding of composite on their lower or upper teeth, if their intercuspal position changes, then we go into the reorganized territory. And when we go into the reorganized territory, we have to accept that there are cases that we will have to manage in their centric relation, and some which we may not be able to manage in their centric relation. Now, that is not the merit of today's presentation, because understanding and applying occlusion into tooth wear, or vice versa, i.e. managing tooth wear patients without an understanding of occlusion, can be one of the biggest challenges we've all faced at some point in our lives. The aim of any restorative treatment involving tooth wear patients is to ensure we establish good anterior guidance. This concept of anterior guidance is simply related to ensuring we have stable and even contacts in their new occlusion, their new intercuspal position, which may not be in centric relation, but you don't have one tooth contacting one from the maxilla to the mandible. You want all 6 teeth anteriorly to touch in their new intercuspal position. You want in protrusion patients to have shared contacts, and you want in lateral excursions the canine teeth to be taking over, so the canine guidance concept. So even contacts, shared protrusion, and bilateral canine guidance. And by that, what we allow is the posterior teeth to disclude when the patient is in dynamic movements and in function. Posterior teeth don't, like lateral forces. This is a patient who presented to us, and in addition to considering the orthodontics, the whitening, principles of smile design, how much teeth you want to build up, what will look systematic for them, can be achieved by principles of smile design. This is again a big topic in itself, and perhaps something you must familiarize yourselves with, but it is ensuring you communicate how much addition of composite or restorative material, direct or indirect, you're aiming to achieve for this patient. And if you simply compare the lower left 2 in the patient's mouth to what the lower right 2 needs, or what the upper left 3 needs compared to the upper right 3, having a visual showing this to patients, communicating this to the lab with photographs will help you plan and execute your case. And from your wax-ups, you can convert this into smile assessments, trial smiles in the patient's mouth, make any adjustments as necessary, and then take indices of that before you begin any restorative work in the patient's mouth. This topic is so large that covering this within 45 minutes is virtually impossible, as you will appreciate. But what I want to show you today is 3 cases which Rahul, Victor and I will share with you. Scenario 1 that I want to show you is a patient that presents to us. Either we are not in a position, because of the systems that we work in, to provide comprehensive textbook standard care. Then what do we do with such patients? A bit like Adam, who presented earlier on. Or do we do the classic textbook standard wax-ups with wax-ups and then centric relation in trying to open the patient's mouth? And there are cases where we will have to even restore missing posterior teeth, either with dentures or implants. There are numerous other examples, but due to time restrictions, we're not going to be able to cover everything. So I will start by showing you a very simple case, a very young lady where resources were limited, time was limited, and patients were not able to afford treatment. In this particular case, this young lady who was in her 17, 18 years of age presented to us with generalized severe wear. It was intrinsic erosive in nature. As you can see, she had some Invisalign done before, but she'd stopped doing this because it didn't work well for her, sadly. She had severe reflux. She's undergoing a vast array of medical investigations and treatments, and still currently not resolved. And for somebody who's 17 or 18 with such severe wear on her maxillary and mandibular anterior and posterior teeth, and has had multiple endodontic treatments, as you can see, for example, on the upper left 6, upper left 3, both central incisors have already been treated. I felt, even though she was undergoing medical investigations, and I know whatever I'm going to do will temporarily work and temporarily fail, the best thing I can do for her is protect all of her exposed dentin. So I booked her a 2-hour appointment, charged her what my hourly rate was, and parents were willing to pay for that. And all I did was freehand composites. There were no wax-ups done. As you can see, I've left the upper right 7 tooth out in this particular case. And it was simply because after seeing me, she had an appointment with the endodontist later on in the afternoon to access. But as soon as she had seen the endodontist, he had put composite on the tooth. There was no wax-ups done. There was no anatomy to these teeth in whatever form or shape. I'm simply protecting the patient's exposed dentin. And perhaps they will come off. Perhaps they will need regular repairs and replacements or maintenance. But until her medical condition is stabilized, all I am trying to achieve is further tooth loss. There was loss of restorative material, but not tooth. I'm now going to pass this to my colleague Victor, who will show you a case with a similar presentation where wax-ups were not used. Over to you, Victor.
Hi everyone, welcome to the Management of the Worn Dentition webinar. This is one of the 3 cases we have for you today. My name is Victor Gehani. I'm a general dental practitioner with a special interest in implant dentistry and restorative dentistry based in Hertfordshire. I'm also one of the directors of the Advanced Centre of Excellence, which is a postgraduate teaching centre based in North London. So we have 3 cases for you today. This is one of the 3 cases. of a worn dentition. So let's start off with the case. So here we have a lovely patient who I treated about 4 years ago, Mrs. A.S. Mrs. A.S. presented as an irregular dental attender who had last seen a dentist about 4 years prior to that appointment. Medically, she was fit and well, did have a past history of reflux, which was now well controlled. She's socially a non-smoker and consumes probably 2 or 3 units of alcohol a week, mostly on the weekend. So here is a front profile photo of her teeth and occlusion. What we noted on the day of the appointment is we've got a BP score of 212121. So just generalized bleeding, a little bit of calculus in a couple of the quadrants and the lower anterior teeth. Plaque scores were about 30% because she had not seen a hygienist for several years and admitted that her cleaning regime at home was letting her down. And we had a bleeding score on bleeding on probing of about 25%, so about a quarter of the dentition was bleeding when probed. We did take some radiographs, and I can assure you there was no evidence of caries or bone loss anywhere, so the radiographs were completely unremarkable. So on presentation, she presented with a main complaint of her teeth feel a little bit sensitive when she has cold drinks. They feel a little bit rough, and interestingly, sometimes food, mainly pips and seeds, get stuck in between her teeth or sometimes in her teeth, and she's constantly having to pick these out, which can be a bit embarrassing. It's not causing her a lot of distress, but she is aware that the teeth have discolored also, and generally feels like something needs to be done to sort of improve the appearance, and it will be nice to not have them feeling so sensitive. The signs that we can see in her mouth immediately are that she has lost some surface anatomy of the teeth, to do with the tooth wear. A BWE score or examination score of 212 was noted, which mainly indicates that alongside losing some surface anatomy of the enamel, we do have some exposure of dentine and wear on the dentine, less than 50% on certain posterior teeth. The teeth are also visibly discolored, and as the surface of the dentine shows up a more darker color, this can be clearly seen on her posterior teeth more than the anterior teeth. So we go back to the picture again. We've got a case here, a fairly common case that we all see in practice of generalized tooth wear, and the most common etiology in this case is mainly erosion. Now we know tooth wear is multifactorial. It's often a combination of erosion, attrition, and abrasion. Abfraction is still sort of discussed as a possibility. But in this particular case, erosion seems to be the predominant factor, especially when we have a history of reflux, which was, several years ago, but I believe did last for about 6 to 7 years. So the acid reflux in her mouth has sadly worn the surface of the enamel, mostly the posteriors at the back, and this has led to sort of that cupping defect where the enamel is worn and the underlying shiny brown dentine can be seen. There is, of course, some signs of abrasion as well, which you can see in the profile photo. And as we know, once we've lost the enamel surface that protects our teeth, it almost provides an umbrella effect protecting the dentine. The dentine is often 4 to 5 times more likely to be worn down once the enamel is worn. So that's one thing to bear in mind for tooth wear cases. So what's key for every patient we see when it comes to a tooth wear case is to get the right diagnosis, get the patient involved in an appropriate treatment plan, and then focus on a plan of treatment, which is essentially how you take the treatment plan forward. How many appointments are needed? What does the patient have to do? Are there any other people in your team, such as the hygienist or a therapist who have to get involved? And that's how we take the treatment forward. So if we proceed forward, for any treatment plan to work, it's very important for the patient to have buy-in. The patient needs to sort of take ownership and take responsibility of the situation of their teeth, where they are, and where they will hopefully end up after the treatment, and can they maintain all that work that you're about to do for them. So it's an element of co-diagnosis, which is a word I really like. I often sit my patients down and really show them their photographs again on a big screen and often in the mirror, and identify and highlight the areas which are concerning them and naturally concerning me. And we all know a picture speaks 1,000 words. So when you've shown a patient a photograph like this, or more importantly like this, there are certain parts of their teeth that they can't normally see themselves. And the initial reaction is, oh my gosh, that looks worse than I thought. Now, of course, it isn't worse. It's just that we've given them a clear picture, an exact situation of what their teeth are like. So I like to call that the current situation. So for me, it's very important, both in my letter as well as in my consent process, to really describe to the patient what their current situation is. So in this particular case, it would be a conversation followed by a letter outlining to Mrs. AS that the following teeth show signs of wear, signs and symptoms of wear, and identify a problem list of each particular tooth, giving the patient an idea of how much wear the patient has. And often in my letter, I can take a slice or a photograph of the patient's teeth and actually mark tooth by tooth what I'm concerned about. And that patient sort of gets a much more graphical picture of what's going on. So that's the current situation. Once the patient fully understands the extent of the problem, we discuss goals. So what are the patient's short-term goals and long-term goals? For example, immediate pain, discomfort, teeth being sensitive. These are often short-term goals. Just get me out of pain, what we call as the emergency phase of treatment. In this particular case, Mrs. AS really hasn't got any short-term goals. She's not in any sort of extreme pain. Yes, there is a bit of sensitivity, but the requirement is to sort of fix her teeth, provide back that sort of layer of protection, which can assure her that her teeth won't wear anymore. So we're focused mostly on long-term goals, but it's very important for the patient to decide what treatment suits them. And of course, the difference between both often can be cost and finance, which is obviously very important. It's an important factor when deciding on treatment plans. And therefore, we can then propose the most accurate treatment. Now, we know finance shouldn't really come into the way of treatments, but sadly it does. So it's nice to give the patient a ballpoint figure of the duration of treatment, the time taken, and what happens next if the treatment doesn't work. So it's always good to have a plan B. So I like to document this down to the patient in a letter and identify the patient's goals and how we aim to reach them one by one. Concept you'll always hear at ACE, at all of our other courses, is we believe in one miracle at a time. So this is not a quick fix solution where we can wave our magic wand and do the treatment in one go. Certain things need to be done before we get to the actual treatment to be completed. So we propose a treatment, and I'll tell you in this case what we propose, considering in all of the patient's factors, such as cost, time, what the patient is comfortable with. And then we formulate a plan of treatment, which is essentially a visit by visit plan, identifying what happens on the day, the duration of the treatment, and of course the cost for the patient per day. Now, anything can't be done without some pre-op records. And even for a case like this, if I quickly go back and show you the main photo here, you can see that along with the wear, we do have, some element of dentoalveolar compensation, which is very common in tooth wear, which is a chronic problem, which means if we try and build up this patient's teeth, where do we create the space from? So essentially, there is no intraocclusal space left for us without trimming any teeth down. And we know tooth wear treatment nowadays should not be subtractive. It should be something that we are adding onto teeth. And composite as an adhesive material is a great choice here, where we can add on layers of composite to teeth to build the teeth up, which makes the treatment fairly conservative. So our initial problem here is space, and where do we create the space from? Of course, one thing I've forgotten, and we often do, is before I even see this patient for any treatment, who does the patient have to see? Well, of course, the hygienist for a good clean. We really want those plaque scores and bleeding scores to come below 15 or 20%, 15% ideally. And we want the patient to have a healthy inflammation-free mouth, the periodontium should be strong enough, healthy enough to sustain all the treatment we do, especially when the restorative work goes anywhere close to the margins, as it often does with composite treatment. So what's very important here, at least 1 or 2 appointments in with the hygienist, followed by a quick follow-up to ensure, possibly after 3 or 4 weeks, that we are on the way to a more healthy periodontium. Okay, so let's go back to our treatment plan and let's see what we did. So once we've established that even for a case like this, we need to create some space, we need some records. Now, the more information I have with the patient not there, the more it eases me, facilitates me to formulate a treatment plan, and also helps me and my technician try and reproduce what the patient's lost. Now, often the pre-op records that we would take in this particular case would be in centric relation. That is known to be one of the reproducible positions where we can open up a patient by moving the mandible. Of course, you can open a patient up in ICP. It's not a conversation to go into today in this webinar, but for practical purposes, I like to always take a centric relation record and a FACEBO record to basically have the patient's articulated study cast mounted in CR. So here we have on the left, you can see a FACEBO record followed by a wax up that's done with my technician. It's always important to consider initially asking for an anterior wax up followed by a posterior one, because once you want to show your patient what you can do, it's good to divide it into the anterior sextant followed by the posterior sextant. Once the patient's approved the wax up, you can then make a putty matrix or a putty stent, which can be used to transfer the anatomy through your composite restorative material onto the tooth. Now, showing the patient a diagnostic wax up is a bit like showing a patient a dress or an outfit which is made for them but they can't try on. How does the patient actually know whether these teeth will suit them, will suit the mouth, will suit their lips, and suit their face? Well, we can always use a provisional crown and bridge restorative material like Quick Temp, Luxatemp, and do a quick mock-up of the wax up in the mouth. But of course this will fall out and not adhere to the teeth for a long time. So it's just an idea for the patient to know what the teeth can look like once you've finished. Okay, so here we are. Here's a putty matrix made by my technician. You can obviously make this yourself, and you'll notice it's made with the putty and wash impression material to get those fine details of anatomy to make your wax up and your mock-up, but also your composites a lot more accurate in the mouth, which saves you a lot more time finishing and polishing. Okay, so once you have worked with your wax up, it's good to go with a alternate tooth technique where you use PTFE tape in between teeth, and you then build up the teeth one by one with alternating the teeth. This naturally gives you the space for interproximal separation, so you can pass floss easily and your teeth are not linked together, which they're not meant to be. So again, something like this for the anteriors will probably take me a good couple of hours or 90 minutes. I'm not as fast as composites as I may think I am. And again, to get the anatomy right and the polishing, I would normally go for a canine followed by a central followed by a lateral and vice versa. So the alternate teeth technique using PTFE tape. Of course, not shown in this picture, but any composites that you do in the mouth have to be done under rubber dam where possible, just to avoid any moisture contamination and create that better seal between the tooth substrate and your composite material. And there we are. So once you focus on the top teeth, you can then work on the bottom. I normally prefer to do the lower teeth first to get the rough anatomy of where the lower teeth need to end up according to the lip line, and then I use that as a template for my upper teeth and go back in on the palatal side for final polishing. Bearing in mind, remember, for me the palatal side is more important for function, whereas for the patient the labial surface will be a lot more important for aesthetics. And it's about getting a right balance between both, making sure the function is correct, followed by the aesthetics. And of course, what we're aiming to do here is increase the palatal surface of those front 6 teeth that have been worn down by the erosive element of acid by about 1.5 to 2 millimeters, which is how much thickness composite generally needs to show its compressive strength. And eventually, after you've polished the surface, what you're checking with your articulating paper hopefully is that you've got anterior guidance on your anterior 4 teeth, and ideally, if you can, some lateral excursion on the canines, if not group function. But here I would have aimed to get anterior guidance on my 4 upper anterior teeth, followed by canine guidance on the canines. So that's the case once finished before the final polishing. You can see composites look relatively okay. A bit more polishing on the labial surface is needed to create that secondary and tertiary anatomy. But essentially, we've got a happy patient here who can see a huge change from when they walked in, right from the color, but also for the surface anatomy and the shape. And more importantly, we've got coverage of the exposed dentine, which was once causing the patient a bit of sensitivity, and also the appearance of discoloration and slightly smaller teeth. So as a first stage of treatment, a composite buildup of your upper and lower anterior teeth can be done to re-establish that anterior guidance between the central and lateral incisors and the canine guidance on the canines before you then work on the posterior teeth. So once you've essentially dulled this patient open, you've increased the OVD anteriorly and provided composites between the upper and lower teeth, you can then work on the posterior teeth. Now, for this particular case, the one thing I didn't highlight to you is cost for the patient was an issue, and the choice of indirect over direct was not considered. The patient did have a budget. We were also restricted with time, and the patient preferred to have posterior composites done one by one due to cost reasons. So here, once I've established the anterior guidance on my anterior teeth, I'm pretty comfortable that my front 6 teeth, canine to canine, have established a fairly stable occlusion. Yes, of course, I have propped the patient open at the back, so there's no contact initially on the premolars and the molars. But in this particular case, do you want the patient to dull in posterior teeth that have worn, that have lacked cusp and fossa anatomy, where the cusps have been worn down because of the erosion? Or here you've created a perfect opportunity where you've gained some space because of your anterior composite buildups to actually place some composites. Now here, an indirect option of composite overlays or ceramic onlays overlays would have been a much better choice in my opinion. But again, as I said, due to cost reasons, the patient preferred for me to one by one provide her posterior composites due to time and costs. So here you can see we've started on providing some very basic composite restorations on the premolars and the molars, spent a bit more time shaping the molar restorations and quite happy with that after a polish. And then once that's done, we can finish the case by providing the same restoration on the second molars and on the upper teeth. Again, just to reiterate, if cost and time wasn't an issue, I often would like to do this side by side, so get the posterior side on one side done, followed by the other. But if the patient has any factors such as cost or time, there's no reason why you can't do it one by one, depending on which tooth is the most concerned tooth with the wear or the one that has the most symptoms or signs. So there we are, you can sort of break the case down quite easily. So I think what this identifies is that the management of worn dentition can be done with so many different ways. You could have treated this case possibly without a Facebook record, just by using the patient's mouth pretty much as your articulator, or you could have gone the whole way where every tooth is waxed up and you've got indirect restorations on all the molars and premolars, followed by direct restorations on the anterior teeth, or direct restorations on the labial surface of the anterior teeth, and indirect restorations on the palatal surface, possibly with gold indirect restorations on the canines, which again is a very common choice if patients accept gold in their mouth. So what this case identifies is it's quite a simple case to get your thought process going. There's more than one way to skin a cat, and even for a comprehensive tooth wear case where you've got generalized erosion, you can really treat this in surgery, in-house, with some very basic, simple pre-op records, as long as you break the case down and get a good diagnosis and have the patient on your side. Obviously, the plan for the future would be the patient knows composite restorations where they can discolor. I often like to call them semi-permanent restorations. I know that's not a great terminology to use, but they do need maintenance. They will wear, they will need to be topped up. The beauty of all that is that they're less likely to need any major work which requires involving a lab or replacing the whole restoration. It's quite a durable material that you can repair in the mouth. So if a tooth or any particular tooth wears or breaks down or chips, it can be repaired as an individual filling at some point in the future. Obviously, you have to give the patient an idea of how long these restorations will last. I often say to my patients, if they see you for 5 years, that's a bonus. Within 5 years, they may need to be checked and topped up. Anything more than that, come back so we can learn from it and obviously maintain the restorations in the mouth in the condition that you've looked after them. 3 months hygiene is very important, and again, all patients would see a hygienist to make sure there's no chance of those plaque and bleeding scores again creeping up and the BP score staying down. And of course, we can't forget the etiology. And in this particular case, whilst the patient has said it's been treated, we must be aware that once the patient has suffered from reflux and lost all that enamel, a regular check, a higher recall to make sure there's no changes to the patient's medical history has to be maintained and monitored to make sure that there's no risk of the etiology again creeping up. Because there was a slight element of abrasion involved here, oral hygiene instructions and appropriate use of a softer brush was encouraged by the hygienist, who does see this patient every 3 months now. So that would be my plan for the future, and put the patient on possibly a 3 to 6 month of review or maintenance program, both with myself and the hygienist. Well, I hope you've enjoyed that brief webinar on a particular case out of the 3 we've got for you today. For more information of the course we run or any other courses that we do at the Advanced Centre of Excellence, please do visit our website, and we look forward to seeing you on a future course. Please enjoy the rest of the webinar. Thank you.
Thank you, Victor, for sharing your case. I'm now going to show you a case where we have a mixture of planning in centric relation with and without wax-ups. Again, a little bit of a compromise, a little bit of planning. Resources are limited. You want to protect the teeth. Rahul did a wonderful case which was involving direct composite in the patient's mouth for localized tooth surface loss. And in light of this, I'm going to now pass this to Rahul to share his case. Over to you, Rahul.
Hi everyone, welcome to the Management of the Wound Dentition webinar. My name is Rahul Shah. I'm a general dentist working in Royston, in Hertfordshire, in London and in Stanmore. I got special interest in prosthodontics and restorative work. I'm going to present a case that I did for a patient of mine, which was quite a nice case that we did. The patient was Mr. MT, 61 years of age, with no known medical conditions and no known allergies, regular dental tender, and saw the hygienist every 3 to 6 months regularly. His presenting complaint was that he wasn't happy with his current smile line, appearance of his teeth, and he wanted his teeth to look a bit more brighter, and he wanted to improve his smile. As you can see from the picture, he had a moderate smile line, and you can see localized tooth wear, tooth surface loss from upper right 3 to upper left 3. When we took a picture with the lips protruded, you can see that the teeth are open slightly, so you can see the extent of where that has occurred on the incisor teeth from the upper right 3 to upper left 3 and lower right 3 to lower left 3. His posterior teeth were restored with restorations, but they were all clinically sound, so we didn't have to replace any of those. And also his posterior teeth did not show any signs of tooth wear on them, so we did not have to do any restorative work on those posterior teeth. Financially, he couldn't afford really expensive treatment, so he was on a bit of a strict budget, so we had to plan the treatment according to the budget as well. So the first thing that we did was a thorough hygiene session with the hygienist to get rid of all the plaque, tartar deposits, and also sort of get rid of any extrinsic stains as well. We also embarked on whitening his teeth using the home whitening treatment, and we managed to get his teeth lighter to a shade A2 from a shade A4. Considering his age being in the 60s, I think A2 shade was quite a natural looking shade for his teeth as opposed to getting a B1 shade for him. Once the teeth whitening procedure was completed and he was happy, we then embarked on starting doing the composite build-ups of the anterior teeth from canine to canine. Initially, we started with building up the lower teeth. We did this freehand with no composite build-ups or composite wax-ups. The reason for this was to keep the costs low as he was on a bit of a strict budget. So what we did on that appointment, we isolated the teeth with rubber dam with clamps on the premolars, as you can see from the picture. We beveled the incisal edges of the teeth, sandblasted the teeth, etch, prime, bond, and placed composites over the teeth. And this is what we ended up with on the lower anterior teeth. By building the lower anterior teeth, they acted as a fixed splint and they contacted the upper anterior palatal aspects of the teeth. And in doing so, we managed then the mandible managed to sort of go back in its posterior position slowly, and we kept on reviewing the patient on a regular interval to make sure that the contacts are becoming stable to a point that we monitored over 2 appointments where the contacts on the palatal aspects of the teeth from the bottom teeth were stable in the same position and they did not change. This told me that the mandible is in its protruded position and it's in its CR position. And then I went ahead and sort of recorded that CR position using a lift gauge, and we did a Facebook recording of the maxilla, which was sent to the lab technician to have diagnostic wax-ups done for upper right 3 to upper left 3 composite build-ups. When the diagnostic wax-ups arrived, we got the patient in and we did the composite build-ups from upper right 3 to upper left 3 using putty indices made from the diagnostic wax-up model. And I used the Vanini technique to sort of do the composite build-ups where I made palatal shells of the composites first, then the mesial and distal ridges and freehand buccal surface finish. Got the patient back in a second appointment to do a final polish of the restorations. We also checked the occlusion, and as you can see from the picture, we had even contacts on the lower right 3 to lower left 3, plus shared anterior guidance on the upper anterior teeth and canine guidance as well. The picture on the left hand side is the before picture when we started, and the picture on the right hand side is the after picture once we finished. And you can see again a before and after of his smile line as well, and the patient was very happy with the results considering that he had a limited budget as well financially. Yes, he has got some teeth, premolar teeth with grey restorations there, long-standing amalgam restorations. With time, the plan is to sort of replace those and place white composite restorations, followed by cuspal coverage restorations as they're heavily restored. But this is all permitting in his budget, basically.
Thank you, Rahul, for sharing your case. What a wonderful result that you and Victor have both achieved, and what a great service these patients have had. I'm going to finish this presentation by showing you one case that I had to manage with a combination of direct composites and dentures. Gloria presented to me. She was in her late 70s. She had a lot of labial wear involving her maxillary anterior teeth. She has a moderate to low smile line. When we look at the retracted view, we can see the labial surfaces are quite worn. She's wearing a maxillary partial acrylic denture replacing the upper right two, as well as some of her posterior teeth. On removal of the denture, we can see how adventurous someone had been in extracting the upper right two with a large vertical and horizontal defect associated with the missing lateral incisor. This is the patient in her edge-to-edge occlusion, where we can see the amount of wear involving her mandibular incisor teeth on the labial surfaces as well. Lateral view on the right side. This is her in her centric relation with the Lucia jig. I've used a wax rim to record the posterior teeth, which I can then put on the Gothic arch tracing on the casts that I have at hand before the patient leaves, to ensure everything matches up before I post this to the laboratory. As you can see, I've used temp bond to reline my wax rims just to ensure I get the precision and detail of the opposing cusps against the wax rim, so that the technician can mount this very accurately. Once the wax ups have arrived from the lab, I've done rubber dam isolation, floss ligatures. I like to go as far back as premolars or even molars to ensure that my wax stent, putty stent, can sit on the adjacent premolar teeth, so it's tooth supported. I isolate alternate teeth with PTFE, and just as a tip, I prefer using these interproximal strips before I put the rubber dam, to make sure that my rubber dam slides into the mandibular or maxillary teeth very easily. I even sometimes end up smoothing some of the sharp edges, otherwise your dam will tear. So once the rubber dams on, putty stents are tooth supported. I make my holes using a black marker on the teeth as opposed to using rubber dam stamps, and I did the same with the upper. This was all done in one appointment, the lower and upper teeth. Sandblast all the teeth, etch prime bond. I prefer to change my gloves after sandblasting because I don't want this aluminum oxide powder to incorporate into my instruments or materials that I'm using. I will etch, but I will dry the teeth after washing them with my suction as opposed to with the triple syringe, because you will always get that last bit of water ending up on the teeth, which you have to dry even more. Alternate teeth are isolated with PTFE, and this is the final result. The key here was not only aesthetics, but also ensuring we get good anterior guidance. Now that we've got to this stage, we almost start afresh and say, okay, anterior guidance has been set. You will see the occlusion in a minute. I need to start replacing the missing maxillary teeth. You could do the same with the mandible, but the patient wasn't keen on a lower chrome denture. Whether you use dentures or implants is immaterial, but at least we've set the tone with the anterior teeth. This is the before and after picture. I start taking my impressions, which will then give me my wax registration reams, and I record that again with temp bond, and you can see here how I've picked up the details of the cusps very well. Lab will make me a framework trine, and in the framework trine I prefer to have 2 posterior teeth, the 6s or 7s, and 2 anterior teeth, but here it was just the lateral incisor, so I can ensure my framework is fully seated and have a visual of it, but I can also test the occlusion. And if my 7s touch and an anterior tooth or teeth touch, the technician can set the rest of the other teeth and proceed directly to a fit without having to do a framework and tooth trine appointment. This may obviously vary from one case to another, but that's just a little tip that I'd like to share with you. This was the end result for Gloria. As you can see, we've got even contacts on the lower teeth. There's a very light contact on the lower right tooth because we have an opposing tooth, which is a denture tooth. And remember the principles of anterior guidance. We've got even contacts of the lower against the upper. We've got shared protrusion, and we've got canine guidance in lateral exclusive contacts. This was Gloria seeing her teeth and very happy, just without the denture in place, just the build-ups.
No, they really look brilliant.
And what a transformation for the
I
patient.
can smile again now. I could never smile for a while, but I can now.
Thank you very much, ladies and gents, and a big thank you to AJ for inviting us to share our knowledge and our passion with you. Thank you, AJ, for not only inviting us, but inviting world-class speakers to this platform. For those of you who are interested in learning more about occlusion and tooth wear, as well as other topics, at ACE we run a number of courses, including single courses as well as a diploma program, whatever takes your fancy. We'd love to see you at future courses, and if there's anything we can do to help, you're always welcome to message us. Thank you once again, AJ, and thank you for all the wonderful causes that will be helped as a consequence of everyone's contributions in this conference. Many thanks.